entitled Focal Point Teachable Moments in Cataract Surgery. So I've kind of extracted out the astigmatism clips and to show it this course. My financial disclosure. So let's start with a video here.
There's going to be a ring of lights. That would be perfect. Can I have lights off in the room, please? So I'm going to need you to bring your chin up just a little bit, okay? And you'll see that ring of lights right there. Just keep looking toward that ring of lights. We can go ahead and dock the patient at this point. Let's go back down. Keep looking at that ring of lights. Perfect.
Under those arcs, because this is registration.
So at this point, I know I'm missing the lids there, so I'm going to look now. We'll look up here. She's nice and centered, so we're just going to come on down there. Still watching the lids. She's nicely centered. She's expert patient here.
This is Dr.
So we can see the bubbles, so we're already. We can go ahead and have vacuum. Go ahead, PI suction. So good, we have good suction. I don't have any bubbles there. So I'm going to go up to the top of the green here. And once we get there, we're going to take a picture.
You see her arc, superior, inferior.
So everything really looks perfect. And she has a nicely dilated pupil. Everything is well centered there. So we're looking at her capsulotomy, and actually we don't have any real lens tilt here, so we have the lowest point and the highest point marked, and this line here marks the highest point on the back side there, which is pretty much flat, so that actually looks really good, so I don't have to change anything. We'll go ahead and accept that. Again, you can see we don't have any lens tilt here. When you do have lens tilt, you're at higher risk for incomplete capsulotomy.
So this is one way for you to...
So I can adjust this a little bit, but I'm actually pretty happy where that is right now. It does give you an 800 micron posterior safety zone, but I'm happy with my lens fragmentation, so we're going to go ahead and accept that. It's going to show me my arcuate incisions. We do have 2 arcuate incisions for this patient. She has about 1.25 diopters of astigmatism, so let's move on and look at that. Those look good. And we're going to verify and accept. I'm going to go to the top of the green so I have good pressure. We accepted all of that, so I'm happy with everything there. So we're going to go ahead and apply to the patient now. We're go ahead and ready to treat. So we have 33 seconds of treatment. Be nice and still, don't move, don't talk. We're treating now so we can see our capsulotomy going around.
I always love seeing that nice 360 show up on the
So we have 25 seconds left. Everything is perfect. She's a perfect patient, nice and still. We're down to 20 seconds right now.
Here's her frag pattern.
We can see the lens fragmentation now. We're doing some spheres, and then we have 3 cuts. That looks beautiful. We're down to 10 seconds.
And there's the arcs.
Everything is going beautifully. So we're doing the arcuate incisions. We have 5, 4, 3, 2, 1. Vacuum's off. And we're going to go ahead and go up. She did a beautiful job.
All right, so the beautiful thing about femto is that you have registered the patient sitting up in your office. You've taken the picture, and now you have the patient laying down under the laser, and it will look for scleral vessels, and then it will look for iris crypts, matches any cyclorotation. So when you put the arcs on, you have it where you have calculated them to be, and it'll also show you the degree of cyclorotation. So then you can go into the OR, and let's say I often am doing a combination of arcs and toric IOL. And I might do very small arcs, 20-degree length, just to mark the axis properly. And I can rotate the IOL to that axis. And if I check it with Virion or Aura, it very seldom needs to have any movement because it's been registered. And that's, so now let's go with, I believe this is John Riddall.
Barrett was calling for a T4 lens, even though she had 2.02 diopters of astigmatism. We got very consistent results here for us with 1.25 diopters of aphakic astigmatism versus 1.2. And so we'll go ahead and do a change to a 21.0 diopter lens, and I'm going to go ahead and go with the T4 that was recommended. So isn't it interesting that the keratometry measurements called for 2 diopters? We read 1.25, and it's still a T4 lens. The reason for that is because aberrometry is taking into account the measured posterior corneal curvature, where the Barrett lens is estimating what the posterior corneal curvature would be, and in this case, they're similar. The other thing that I really love Aura for is aligning toric lenses precisely. Our pre-op measurements suggested an axis of 103, Aura suggests an axis of 105 degrees, and I'm going to be able to put a reticle there that shows me exactly where 105 degrees is. And if you notice, we did have a 6 o'clock mark, but we don't even really use it because we go off of what the Aura measurement says. You know, a lot of us would naturally be inclined to think that astigmatism is going to affect multifocals more. Our data from Astigmatism Fix actually doesn't show that residual uncorrected visual acuity in multifocals and in monofocals is the same for a given level of residual astigmatism. So now, if the numbers match up well, which they do in this case, I just make sure I get my toric lens lined up exactly where I want it to be, and the reticle is exactly where I want it to be. I love that alignment. So then I get the viscoelastic out from behind the lens. You know, one of the things in particular that I like about the Acrosoft platform is its rotational stability. That's really important. So I like to make sure I get all the viscoelastic out behind the eye. Make sure that I like the alignment, which I do. I'm thrilled with it. Put that seat down into position. DSS. Look right at the light. Look down a little bit. Good. So hydrate those wounds well. Some good videos out there showing that most rotation occurs in the first 24 hours, and usually because the IOP is low. Look over to your right just a little. Now look right at the light. Perfect. So I love that alignment. I feel great about it. Get some of that mucus off and then put in an injection and we're done. And so, you know, I feel like she got about as state-of-the-art a surgery as we can do with a toric multifocal and intraoperative aberrometry and good ocular surface management.
All right, so there's an example of using Aura, and that gives you a true refraction. So we always talk about anterior posterior corneal curvatures, and you can estimate them. A lot of people don't have equipment to actually measure a true K. So, but Aura will do it for you because you're actually getting a refraction.
And we calculated right around a 16 diopter lens for Plano for her, but I definitely trust the Aura more than I trust my measurements. We've been more accurate with it, so we're going to check it. I'm going to turn my room lights down here. Now, I'm going to have you looking at a red light. Here, you want to see that red light? Okay, I want you looking directly at it. Good, and we can capture.
See, tips is what he uses, and that's how he decides if he's got a accurate read.
16.5. Okay, let's do one more just to make sure. A couple drops. The light's going to come back on, okay? Have you found it yet?
Yes.
So you got to align the X in the lower right, look at the pattern, the fringe pattern, upper right,
right there.
and then you get it centered in the big screen.
So very similar. So we have, in the room we have 16.5, 17, and 16. Right?
So these are all ways to refine your sphere, sill,
She's a little myopic now, and she kind of likes it, so I can actually go to the 17, leave about -1/2. Yeah.
We use intraoperative aberrometry on all our premium IOL cases. So sometimes in these patients that were fairly myopic, they may need additional viscoelastic to help pressurize the eye to the proper spot to get a good intraocular aberrometry reading, or you could use something like a Duovisc XL that allows you to do that too.
So once again, good fringe pattern upper right. You focus up and down till you get the X in the middle of the 4 dots.
Yeah, we'll use a 19 diopter. SN6 AD1, please. So this lens happens to be a Restore 3.0, and I like to almost exclusively mix and match the lenses that I'm using. Oftentimes we use
here will be about
active focus in combination with a Restore 3.0
as a way of centering your IOL.
The reason I like that so much is because it allows the defocus curves to overlap, and they have good intermediate and good near vision. And I found that when I try to nuance it too much and pay too much attention to what a patient wants, and they say they never read, and I do say for
filming this year,
and they don't
try
get the reading that they're hoping for, they come back and say that they can't read, and I say, well, we talked about that. And they say, oh yeah, but I do realize now that I do read some, and so we know that everybody reads, and we know that everybody uses intermediate vision. So I think that the mix and match until trifocals come out will continue to be my go-to approach. So I do think that it's important on these multifocal IOLs to have them be well centered. So you'll see that pay attention to the corneal light reflex.
Corneal light reflex.
The other thing I want to mention is you want to make sure you don't have any viscoelastic or gel on the cornea when you're doing an intraoperative aberrometry measurement. You can tell that he was a high myope before his PRK, even without knowing his historical records, just because there's so much room in this eye. And so looking right there, I want to make sure that those Purkinje images are well centered and they look just great.
If the patient look directly at the microscope
make sure the centration stays where we want it to be in this large eye. Okay, good job.
All right, so what do we mean by these Purkinje reflexes? Every surface gives you a reflex. So P1, P2 come off anterior posterior cornea, P3, P4 will come off the IOL. So what you'd like to do is get these to overlap. Now, in a pseudophakic eye, you just substitute P3, P4 will be the anterior posterior surface of the IOL. So people always talk about angled kappas, and you look at a multifocal post-op and you say, gosh, I'm not centered. How come? It might have been centered in the bag when you put it in. The pupil was dilated. But post-op, that pupil could be a little eccentric, and it's often a little bit nasal. So by having the patient fixate on the microscope light, you can, like in the lower right, get those Purkinje reflexes to overlap, or you nudge the IOL till they overlap, and then you can be sure that you have put it in their visual axis, and not necessarily what you thought was the anatomical center. So this is what you're looking for, is to get those light reflexes there to overlap a bit. So here's what you want when you're done. Patient, fixate on the light, and what I'm getting is that relationship on the visual axis, center of the multifocal, and I should be good to go. Tomorrow, hopefully no surprise, right? All right. Any questions?